So thank you all. I know you've all been waiting eagerly to get started working on health reform this year, and I'm happy to be here to present to you the governor's proposal as a starting point for your work. The proposal comes to you today in the form of, actually came to you yesterday, in the form of a bill that was introduced on both the House and Senate sides, and I want to thank Senator Ayer and Representative Larson for introducing that proposal. And it is the product of a lot of hard work over the last several weeks since Governor Shumlin took office across agencies. My job, as I said when I introduced myself to at least the House committee a few weeks ago, my job is to coordinate health reform across all the agencies and departments of state government that are involved in it and will be involved in it for many years to come. And this proposal is a good representation of input from the Agency of Human Services, Secretary Racine, many people at DEVA who helped us craft it, Harry Chen at the Health Department, the Agency of Administration, Steve Kimball at Bishop, who is right behind me, who is central to our effort, and John Franco, who is doing some work for Steve and has also advised us on the legislation. So I want to thank all of those folks for their efforts in helping us pull this together. I did testify before you a couple of weeks ago. I testified before the Senate and before the House Healthcare Committee about the reasons we need health reform this year. And I just want to reiterate those as a starting point for what I'm going to say to you this morning. Those reasons are compelling. There's a crisis in our healthcare system. It's a national crisis, but we think we can take steps this year in Vermont to address it and get us on a road toward fundamental changes that will alleviate the crisis. Healthcare costs too much. The costs aren't distributed equitably. People don't get the highest, we don't get the highest possible value for our money, and people are left out of the system in various ways. So I'm going to go through those just in a little more detail to hammer home, and then I'll talk about what's actually in the proposal. Healthcare costs more than doubled in Vermont. I forgot my quote. Wait, back up. What I'm giving you today, I consider a roadmap, and as Yogi Berra points out, you need a roadmap. So I'm going to give you what I see as the vision for where we're going and how we get from here to there. And I think it's very important that as you consider this proposal and work on it and make it your own, we continue to have a clear roadmap for the steps we're taking along this road, because if we're not careful, we may not get there. So healthcare more than doubled. Looks like we have a compatibility problem between versions of PowerPoint, but you can read it in your written version better. Healthcare costs, healthcare spending in Vermont more than doubled between 1992 and 2009. That growth on average was more than 12 times the rate of growth in the Vermont economy. And you can see in the next slide that healthcare expenditures as a percentage of gross state product have been growing over time. And now, in 2009, actually, we're estimated to be 18.5% of our gross state product. That's slightly higher than the U.S. Percentage of gross state product. And there are some reasons that we can tease out for the differences between the Vermont and U.S. Percentages. But the bottom line is it costs too much. And it costs more and more as a percentage of our total spending every year. And we need to do something about it, or it will squeeze out all sorts of other priorities. The costs are not distributed fairly either. There's cost shifting between Medicaid and Medicare and private payers. We hear a lot of talk about that, and how the private sector is shouldering the burden of underpayment from the public sector. There's also cost shifting within the private sector. So depending on where you fall as a purchaser in the private sector, you pay a lesser or greater share of the cost. So we need to deal with that and have the costs be distributed more equitably. We're wasting money. There's too much spent on administration, duplication, unnecessary or unproven care, and inefficient care delivery. And the second quote I'll use today is from Henry Aaron, a well-known economist at the Brookings Institute. He said, "Our healthcare system is an administrative monstrosity, a truly bizarre melange of thousands of payers with payment systems that differ for no socially beneficial reason, as well as staggeringly complex public systems with mind-bogglingly administered prices and other rules expressing distinctions that can only be regarded as weird. I think that sums it up, and I think you see this expressed in the experience of consumers, providers, lawmakers like you who try to make sense out of the system. It's just too complex and too hard to set new policy around. So we're going to try to address that this year. Vermont's somewhat simpler, but still way too complex. With 2 commercial carriers, 2 public payers, numerous workers' compensation carriers, which we propose including a review of that in our proposal as well. And we need to do something about simplifying all of that and using technology such as electronic medical records and a health information exchange and appropriate quality oversight to make the delivery system more efficient, more provider-driven, and less wasteful. So lastly, my last point before I get on to telling you about our proposal, despite the staggering cost of healthcare, more than 47,000 Vermonters were uninsured in 2009. Another 28,000 had insurance at that point in time, but were uninsured at some point during the previous year. And as many as 90,000 additional Vermonters are considered underinsured. So there's an enormous portion of the population, more than a quarter of the state's population, potentially facing health care bills that they can't afford that could send them into bankruptcy, while the rest of us pay essentially a hidden tax for the care that people who are uninsured and underinsured receive and are not able to pay for. So today we are giving you the Shumlin administration's recommendations for addressing these problems. And as I said, I know you've been anxious to receive it. I know you also will find flaws in it. It is not perfect. We've done our best to work over the past 4 or 5 weeks to make this a proposal that we're proud of. But we know that you'll find ways to improve it and change it, and that is expected. We don't think we have all the answers, but we think we're putting in front of you a solid proposal for moving forward with major, meaningful reform. The proposal will not satisfy everyone. In particular, we will disappoint those who say that we should delay real cost containment until we know precisely how we should do that. What we're proposing is that we begin a process of developing a better system for containing healthcare costs in Vermont this year. That's going to be a developmental process. We have to work with healthcare providers to figure out how it's going to work and how it's going to stick, but not be a stupid system like some of the systems that government has used in the past to control healthcare costs. But we have to get that work underway. We will disappoint those who want to see a publicly financed single payer immediately, because we are not proposing to you that we immediately implement a financing system for a single payer healthcare system. We propose taking full advantage of federal funding to cover uninsured Vermonters, and that money flows under the Affordable Care Act beginning in 2014. We also propose a more thorough analysis of costs, potential savings, and potential financing mechanisms for a publicly financed system before we ask you to endorse a specific financing plan. But regardless of the funding mechanism chosen, ultimately, we recommend including in the planning for the exchange the development of a single channel of payment for all health insurance claims, which is a central component of the single payer system. So we're going to ask you to endorse planning for these functions that are central to a single payer and further analysis by the administration of costs and potential financing mechanisms for a single payer over the next couple of years. Our proposal also may scare some people who have defined roles in the current system. Change is scary. Uncertainty is scary. And one thing we are not bringing to you today is a proposal that nails down all the details and tells everybody exactly how it's going to work. And I don't think that we could reasonably or responsibly do that. But we are putting in front of you a framework. I described it to someone this morning who used the metaphor of a building. We're building a building. You live in this building here. We're building a building next door because we need to replace this building. You don't have to move to this building right now, but we're going to build it over the next few years and eventually ask you if you want to move in. And I think it's a useful metaphor in the sense that we are not changing how people get their health insurance right now. We are trying to make a difference in terms of costs in the system and get a handle on cost control. But we are not fundamentally disrupting the system. But we're talking about changes down the road that will make the system different for people who work in it, people who use it, et cetera. And we will need to work with you and articulate those impacts over several years. Lastly, we'll disappoint those who are hoping that the complexities of real health reform will cause us to propose something less ambitious than a single payer. We're going to lay out a plan for you that takes you from where we are now to a single payer over a multi-year period. That is our goal. That is the governor's stated goal. And he's behind it, and he feels that the best way to ultimately control costs, simplify the system, and get health insurance off the backs of employers is to move to a publicly financed healthcare system. So we will continue to explore that and bring proposals to you to implement that over time, and to the federal government at the point that we need to ask for their permission to take that step. Before we finalize this proposal, we talked with Dr. Shao and his staff about the comments and questions they received regarding the plan that he gave you a couple of weeks ago. We wanted to make sure that we incorporated those in our thinking and in our design to the extent that we could. Dr. Shao received 159 comments in total, with more than 100 of those coming from individual citizens, and then others coming from provider groups, business groups, unions, and consumer groups. The questions and comments ran gamut from I love it to I hate it and everything in between. Some were simply a statement of support or lack thereof. But a lot of the questions got to the details of how does this affect me? And in particular, there were lots of questions about financing. How certain can we be about the calculations of costs and savings? What's the impact of the payroll tax that he proposed on various specific circumstances? And then you've heard a lot of those questions as well. He had a lot of questions about benefits. Will various specific benefits be included in the benefit package in particular? What will the scope of benefits be? How will that compare to my current benefits? And so forth. And then questions about provider impacts. How will the new system work? And what does it mean for healthcare providers? So we made an attempt in crafting our proposal to address these issues. You've already heard me talk about the financing. We propose more analysis on that. And we propose a structure for determining benefits that will kick in the future. So, and then on the provider impact front, we propose, as I said, this cost control system that involves providers working with us to figure out what's the best system moving forward. So what is our proposal? Broadly speaking, we recommend 3 stages of reform that span at least 4 years. In the first stage, which begins July 1st of this year, we propose taking 2 important steps. We create a health benefit exchange and a Vermont Health Reform Board. The exchange, which is permitted under federal law, is essentially a large purchasing mechanism for people who have health insurance, and also a mechanism for administering new federal tax credits to people who will receive tax credits under the Affordable Care Act. The Health Reform Board develops payment reform methodologies and cost containment methodologies that will result in sustainable rates of growth in healthcare spending in Vermont. So those are the 2 sort of concrete steps that happen this year. And then we do a lot of work within the structures created by those 2 entities to further develop the reform plan and take us further down the road. The exchange is intended to serve as a marketplace where people purchase insurance, where they essentially, someone can come in and do an apples-to-apples comparison of an array of insurance plans and make a choice, and to the extent that they're eligible for some sort of subsidization, that gets factored into the price that they pay to the exchange. States are given fairly wide latitude about what exchanges can do, and probably at one extreme we have a state like Utah, which has a pre-existing, they already had something called an exchange before the federal law was passed. It is essentially a website where all insurance plans are listed. There's no criteria for what gets listed as a plan. They take all comers, and it's just laid out there so somebody can easily go to one place and find out what's available to them. Massachusetts is more of the active purchaser model, where they set some standards for what gets included in their exchange. They have a very simplified array of plans, and they negotiate with plans to set premiums each year. Whereas in Utah, they let the prices be what they are. So the state has the authority about where on that range they want to be in terms of the functions of the exchange. They also have authority about how many exchanges there are within a state, how broad a population to include in the exchange, how many insurers to contract with. Under the federal law, the state has to contract with at least one private insurer to serve the exchange to provide health insurance to people. But the state can selectively contract with as few as one. There are some constraints in the federal law. As I said, the exchange has to provide coverage through one or more licensed insurers. It has to offer benefits that meet or exceed a federally defined essential benefit plan. And that essential benefit plan is expected later this year from the feds. It will form the floor for what's offered in the exchange, and states can exceed that level, although the state has to pay for any subsidization that exceeds that level. And in the exchange, you have to offer 2 federally administered health plans that are still to be defined by the feds, but there has to be access to these federal plans as well. What we are proposing is essentially the broadest definition of that exchange that I've heard of to date, in terms of how much of the state's population we'd like to include and how much we'd like to use the exchange as a vehicle for driving administrative simplification, payment reform, cost containment, and other policies that we think are desirable. So if you've got the active purchaser model in Massachusetts, as I said at a meeting yesterday, this is the wicked active purchaser model. This is the purchaser model with greater bulk in terms of the population and greater authority in terms of driving system change. So we believe that the benefits of the exchange, the federal funds to design and build it, federal funds to replace our aging technology in our Medicaid program for processing claims and enrolling people, and federal funds to subsidize uninsured Vermonters make it worth operating within these federal constraints. And I just want to take a moment to note that federal funding for redoing our claims processing and enrollments, our eligibility systems. A lot of states, when they saw the federal law and saw the exchange provision, said, well, we need a whole eligibility system for this exchange, and logically we would use our Medicaid system because that infrastructure lives there. But almost every state has ancient technology, ancient in the technology world, 30, 35-year-old systems that are really difficult to build new functionality into. The feds recognized that and made available 90-10 match, 90% federal dollars, to rebuild claims processing and eligibility systems. So Vermont, like many states, will be taking advantage of that. And we think that those pieces of infrastructure can really be the guts of our new system going forward. We also believe that we can use the exchange, as I said, as a platform to bring many of the benefits that Dr. Shao described in his single pipe concept in terms of administrative simplification, transparency, and cost control to as much of the Vermont population as possible. Now, this particular slide is not in your slide deck because I did it about midnight last night. And you can tell that I think some of the lines are slipping. Starting to get a little sleepy. The idea here is, and this is actually, believe it or not, this is derived from an illustration that Richard Slesky gave me of an idea that he and Peter Welch brought to the legislature in 1992 or something like that, for how the state might combine various funding streams to have a single pipe and administer it in a much more simplified way. So the idea here, and again, this is conceptual. We have to figure out exactly how to do this. But the idea is that you have private funds, federal funds, and state funds all flowing into the exchange, and that we contract with one or more licensed insurers, and then that at the bottom level, the pink level, we have a reform delivery system to which we make payments. And this will be something that obviously we'll have to explain in a lot more detail to you, but that's the big idea of where we end up with the exchange. Now, ultimately, that turns into, go back to it, ultimately, if this is tax financed, all these funds, some of them are already in the system from existing public financing flows, but the private funds get replaced with some sort of public financing. But the point is that the mechanics really remain the same. What you do is change where the private funding is coming from. And obviously, a lot more to come on that. So we are proposing that, back to this. We are proposing that we bring to the legislature in 2012 the details of how we would combine funding streams through this exchange. We're calling it an integration plan. You can read in the bill what components there are in it, but basically we say that we'd like to come back to you and describe how, describe how all of these potential populations and programs get included in the exchange. So if you look across the bottom at all the little boxes, we will come back to you and talk about how Medicaid, Medicare, dual eligibles, those who receive subsidies under the Affordable Care Act, fully insured groups and individuals, public employees, both state and municipal, and workers' comp, the medical portion of workers' comp, how all of that would get integrated through this exchange. Obviously, that's easy to say, but it's going to be very complex to do, and so we're going to come back to you with details of the extent to which that is possible, and how it would work and how it would be staged over time, and what kind of benefits